Welcome to another session of Cardiac Imaging Agora. I'm Andreas Yiannopoulos from the University Hospital of Zurich in Switzerland. We will discuss today about hybrid cardiac imaging in chronic stable coronary syndromes and more specific hybrid imaging using cardiac computed tomography angiography and SPECT myocardial perfusion imaging. To give you an overview of today's tutorial, we will at first discuss what is hybrid imaging, why do we need hybrid imaging, followed by a step-by-step demonstration on how to perform fusion of CTA with SPECT-MPI using a case example, and finally we will discuss potential pitfalls and troubleshooting. So to start with, hybrid is a more general term referring to basically an offspring or in general a product resulting from combining the qualities of two organisms of different breeds, different varieties, different species. For example, the centaurs that were creatures from Greek mythology with the upper body of a human and the lower body and legs of a horse, or hybrid fruits that since centuries have been part of our diet, or even hybrid engines, electrical and gas that are becoming increasingly popular the latest years. So what is hybrid imaging? It is defined as a combination and fusion of two datasets of different cardiac imaging modalities by which both modalities significantly contribute to the acquired information that we get. Physicians have long mentally fused information from different modalities that, combined with the clinical status of the patient, has allowed them to decide on the diagnostic approach and the most appropriate therapeutic management. Now, this integration of information from a single or usually from multiple cardiovascular imaging modalities enables synergistic assessment of firstly the presence, the extent and the severity of coronary and atherosclerotic disease, and secondly hemodynamic information on the significance of these lesions, as well as evaluation of the myocardial function. In the era of multimodality imaging, the advent of hybrid imaging has eased this mental fusion of the well of information available. But let's look on the forms of hybrid imaging. There are several, and almost everything can be fused together. The ones that are currently in use include coronary CTA with SPECT myocardial perfusion imaging, CTA with PET myocardial perfusion imaging, CTA with cardiac magnetic resonance imaging, as well as more recently coronary CTA with stress transthoracal echocardiography. Taking a step back now, let's look on the diagnostic pathways of suspected coronary artery disease, because the latest guidelines on chronic stable coronary syndrome from the European Society of Cardiology have upgraded the role of coronary CTA in the diagnostic approach. We do know that on patients that are of intermediate likelihood for obstructive CAD, prior to selecting a diagnostic test, several points should be assessed. For example, for patients with low clinical likelihood, no history, as well as when the information on the presence and extent of atherosclerosis are desired, coronary CTA should be preferred. On the other hand, when the likelihood clinically is high and rather non-invasive ischemia testing should be preferred. And in patients where coronary CTA does not help us to evaluate the hemodynamic significance of a lesion, addition of functional imaging for myocardial ischemia is recommended, having a class 1 level B indication. And why is this important? We do know that for the prognosis of patients with stable angina or with silent ischemia, a large area of ischemia detected by functional testing, functional imaging, an area of more than 10% of the left ventricular myocardium, has a class 1 level B indication according to the latest revascularization guidelines from the European Society of Cardiology. So why is hybrid imaging important? It is well established that the anatomical severity of coronary stenosis, as measured by either invasive coronary angiography or by computed tomography angiography, does not correlate well with the presence and extent of myocardial ischemia. As the degree of stenosis is a poor predictor of ischemia, using mainly anatomical criteria for revascularization in patients with chronic coronary syndromes has not demonstrated to improve survival. Furthermore, the standard 17-segment model of the myocardium that has been long used for the localization of myocardial perfusion defects has been shown that in a significant number of cases does not always correspond to the presumed coronary artery territory. Data from the EVINCI study, a sub-study of the EVINCI, showed that the use of hybrid imaging can improve proper co-localization of myocardial perfusion defects by in about 18% of the patient, an effect more prominent on the right coronary artery lesions and on the circumflex lesions. So why should we use hybrid imaging? Hybrid imaging can allow us to exact match the perfusion defects to the corresponding substanding coronary artery, and therefore help us to avoid unnecessary invasive angiographies and revascularization procedures. In the end, it can help us to guide appropriate management of the patient. Hybrid images are usually generated from different modalities and displayed in 3D reconstructions. The use of dedicated hybrid scanners is not actually necessary, but what is necessary is dedicated fusion software. This software should allow for accurate co-registration and should accounting for the respiratory and the cardiac motion. One issue that has been aroused with the use of cardiac hybrid imaging is the increased radiation exposure, and this can be tackled on the one hand for the computed CTA with newer generation scanners, different protocols as prospective triggering on scanning, as well as newer reconstruction algorithms. And on the SPECT side, for example, newer cameras like the CZT cameras, as well as improvements in tracers and protocols, can nowadays allow the acquisition of hybrid imaging with less than 5 millisievert per study. Now let's see how to perform the hybrid imaging. This is just an example. This is the way we perform hybrid imaging in my department. It could be slightly altered, but this is something that I do suggest. You can start with any exam. You can either start with a CTA or with a myocardial perfusion imaging. Ideally, we do start from the CTA because a normal CTA in the majority of cases can allow you to skip the second step. Just don't do the functional imaging, and also respectively don't perform the hybrid imaging. So once you perform the CTA, one should assess the need for functional images. Are there any lesions that are of intermediate importance? Is the scan not diagnostic? And then further perform the non-invasive functional imaging, these being either, for example, SPECT, PET, or CMR in the majority of cases. The next step would be to assess the need for hybrid imaging. Do you see a perfusion imaging defect, or is the myocardial perfusion study normal? If it is abnormal, and we presume that the hybrid imaging will provide more information, the next step is to fuse the image and assess the matching of anatomy with function. Now let's see a case example that was referred to our department, and it refers to a 68-year-old female patient with a history of hypertension, which was well controlled under AT2 and calcium antagonists. She had also hyperlipidemia that was not under medication, and she didn't have any other traditional risk factors. Her symptoms were rather atypical. She didn't have any chest pain, and she didn't have any dyspnea. So what was pathological was the ECG that, compared to a year ago, it showed a new T-wave inversion in the V2 to V4. A transthoracic echocardiography was performed, and it showed eccentric hypertrophic left ventricle with normal ejection fraction and with non-regional wall motion abnormalities. The patient was referred to our CTA, which was performed on a 256 slice CT scanner with a slice thickness of 0.6 millimeter and with a doses of less than 0.5 millisievert. The right coronary artery and the circumflex artery were absolutely normal, but what we did see was an intermediate to high degree stenosis at the proximal LAD. As you can see here on the 3D reconstruction, on the MIP images, and on the long axis images. Now, taking a better look on the axial images of this plaque, we see that this is at least a 70 to 80% stenosis with, to my opinion, high risk features with low attenuation plaque and with a kind of external remodeling. The next step was to perform a SPECT myocardial perfusion imaging on a CZT camera scanner. We used the stress rest protocol with technetium and with the stress induced with the help of rigadenosone. The total dosage was 5 millisievert for both stress and the rest images. What we can see now from the slices is that the patient had an anterior from mid to apical perfusion illustrated on the polar plots map. We can see that the defect is approximately at least 15% of the myocardial mass. So we have a pathological CTA, and we do have also a pathological myocardial perfusion imaging with SPECT. The patient would indeed probably go to the cath lab to revascularize the lesion, but hybrid imaging might be of use here or would be helpful for the interventional cardiologist. Now, how we can fuse those images? I will describe you now the steps and the potential pitfalls that one might be encountered with. So the first step is to select the proper exams of the patient from the patient list. Then using the dedicated software, you should launch the hybrid volume viewer and select the appropriate protocol. Depending on the vendor that you use, these have different names, but most of them are under a hybrid or fusion protocols. The next step would be to select the appropriate series. The input dataset should consist of one coronary CTA phase, and for the myocardial perfusion imaging, either one specific gated bin as transaxial slices or the summed gated bin as transaxial slices. Commonly, and it's logically that we just use the stress dataset along with the CTA images, because we do want to match the anatomy with the stress defect. Next step is to co-register the two images. Usually I do prefer to perform it manually. When you open up the software, you do see usually an attempt of the software to match the two images, to register the two images, but in the majority of the cases this is not successful. Now the registration can only be visualized on a small part of the volume. Therefore, I suggest that you carefully study the entire volume in all rotations before making sure that your matching of the registration is accurate. You should check that the myocardial perfusion imaging signal is inside or is outside the external limits of the left ventricular epicardium, and then properly move it in order to match. This is a rather simple procedure. You just have to do it a couple of times to get accustomed to how your software, how you can use your software. The fused images must always be consistent with the CTA and the SPECT they result from. So take extra care on looking through the entire volume. The next step is the left ventricle epicardial segmentation. Usually this process is automated and is well done automatically, provided that both scans are performed well. The color of the CTA object is computed based on the perfusion information that we have from the MPI imaging. The center of the epicardium is displayed as a cross on the axial slices, and each point of the surface on the CTA, the color is computed based on the maximum perfusion intensity on a rayon information from this point through the center of the heart in the CTA. All the perfusion information that is taken into account in the computation of the mapping must be included in the contours displayed on the fused images. And this, again, it's important to page through the axial slices to see if there's a really good matching and a good segmentation. This stage you will be encountered with some pitfalls, either an improper segmentation or an over-segmentation or an under-segmentation. In some cases where you do have not the ideal quality of one of the two scans, the automated algorithm might not work at all, so you have to manually segment the left ventricle epicardium. I do show you here two examples of over-segmentation and under-segmentation, corrected with several tools that are available usually through the scanner, either by trimming the extra structure or by sculpting using thresholding to add structures or part of the left ventricle epicardium that are not included. Once we're ready with our left ventricle epicardium, we move to the next step, which is the coronary CTA segmentation. The first step here is to analyze the coronary arteries. I suggest always to scroll through the images using different projection, different from either the axial or the sagittal views, in order to get a better feeling of the course of the coronary arteries. Now, this process can either perform automatically or preferably semi-automatically. If you have a good quality of a CT scanner, scan, then usually it's a rather easy step. If you do it semi-automatically, you should select several points along the path of the coronary arteries, starting with your start point, which should always be rather inside the aorta, rather closer to the coronary ostium. Make sure here that all arteries are properly analyzed and identified by the software. You can do this more reliably in the maximum intensity projection views. That you might be encountered with is that you don't have a proper segmentation of the path of the center line. So I suggest here to examine carefully the trajectory of the segmented arteries prior to moving to the next step. You can either modify the center line here, or you can correct and add new points on the vessel that are not segmented. Once you're certain about your segmentation, perform a visual check of the coronaries and manually add missing arteries. In this step, for the algorithm to miss some vessels, it usually refers to smaller branches. I show you now a more extended defect, and how the algorithm here missed in the entire part of the proximal to mid LAD, and how I manually, basically with thresholding in this case, I included it again. Important, sometimes structures that are not coronary arteries but do have enhancement in the CTA images are falsely identified from the software as coronary arteries. Here you should either trim them or remove with the use of thresholding. In this example, I can show you that a septal branch that was closely to this lesion on the proximal LAD was completely missed. both on the from the automated algorithm as well as on my semi-automated approach, and then I did have to add it manually. Just a reminder, you can potentially go back to every step and correct defects either on the myocardial perfusion imaging segmentation or on the coronary CTA segmentation. Once you're happy with your coronary artery segmentation, you move on to the next step, which is the superimposing of the two imaging. Usually the algorithm just superimpose or fuse both the MPI and the CT images automatically, including also other structure. Most importantly, in this example, the left atrium as well as the pulmonary arteries. Basically structures that are closed to the region that is of our interest and have bright contrast enhancement are also included in these models. The good thing is that these models can be easily removed by just unclicking them, and you get to the final result on the right. The next step is to adjust the leveling of your images. The leveling must always be consistent to the SPECT images that your hybrid image results from. You can see here two examples of under leveling or with over leveling. This might be an issue with the your hybrid, your fusion software, but you can always adjust it and manually type in the numbers that basically make sense. There's not an automatically procedure to account for that, but it's a rather easy step. And looking on the polar plots, basically you can adjust the leveling in order that it makes sense. And the final result is these beautiful hybrid images that you can either present as snapshots or as rotating images or as videos. You can zoom in, you can basically focus on the pathology, on the myocardial perfusion defect and the corresponding artery that subtends this region. In order to close the case, the patient was indeed referred for invasive coronary angiography, where indeed it was shown to have a significant stenosed lesion on the proximal LAD, which was treated with one drug-eluting stent. You do see here the final result with a proper expansion of the lumen with a stent, and the patient was relieved of her rather atypical symptoms. Some take-home messages now. Hybrid imaging is defined as the combination and fusion of two image datasets by which both modalities significantly contribute to the information that we get from this image. Any combination imaginable is possible. The most helpful, the one that makes most sense, is morphology plus function plus hemodynamic significance of lesions. Extra care should be taken to avoid pitfalls on the co-registration, the left ventricle segmentation, the coronary segmentation, as well as on the leveling of the fused images. Don't forget, it's really important that your hybrid image makes sense. You should always look back on the CTA images, on the SPECT, on your myocardial perfusion images to better understand if the image, the hybrid image that you have in front of you actually corresponds to the anatomy and the function of this patient. I would like to thank you for your attention and to leave you for the next time on Cardiac Imaging Agora.